Good evening, everyone, and welcome to the EUROGEN webinar series, and thanks, Darren. I am Michelle Batty, the manager of the EUROGEN reference network, and EUROGEN is one of the 24 European reference networks that are created and funded by the European Commission since 2017. And they all collaborate to help improve care for patients with rare diseases. And in our ERN, we're focused on highly specialised surgery for patients with rare ureteroceles diseases or complex conditions that all need highly specialised surgery. So really where the expertise is rare. So what do ERNs do? Well, some of our activities, we perform virtual cross-border like MDT, expert advice, going to any clinician in any country in the EU that would like help or advice on a patient with a rare urogenital disease or complex condition. So please take note of the slides at the beginning because we'd be delighted to help, and we can be contacted through our website. So please feel free to get in touch. We also collaborate on education and training activities like this webinar series. And one other very exciting development is we have a registry, and that is gradually being rolled out across all our members. And we currently have 56 healthcare providers in 20 member states. So we very much hope to collect some interesting data which will help improve care for our patients with rare diseases and complex conditions. So that's a little bit about what we do. And now to get to this evening's webinar, the title is Duplex Kidney Anomalies, Diagnosis and Contemporary Treatments. And we're really very grateful to one of the experts from one of our members, who is in Gdansk, the Department of Surgery and Urology for Children and Adolescents. And that's in Gdansk, Poland. And it's Stefan Anzelewicz, apologies for the mispronunciation there, Stefan, who is a senior physician and paediatric surgery specialist. Now, I'm very sorry to report that Stefan had some unforeseen circumstances this evening, so it isn't possible for him to be here with us in person, unfortunately. But he has still kindly provided us with a recorded presentation, which we will play for you shortly. And if you would like to ask questions, please put them into the Q&A field, and then we'll take note of them and reply to you after the webinar. So we do encourage questions. It's normally nice to have dialogue but with the presenter, but questions we will follow up on after the webinar. Okay, so hoping and we would also like feedback on our new Zoom platform as well after the webinar, if you would be so kind.
Good morning, everyone. Thank you all for joining me today. My name. Just so you know, I have no conflicts of interest. I will be presenting on duplex kidney anomalies. The urinary system is an incredibly complex network composed of over 40 different cell types, and its development must proceed in a highly organized manner to function properly. When this intricate process doesn't go as planned, various kidney defects can occur. These defects range from renal agenesis to hyperplasia, where the kidneys are reduced in size. Other issues include dysplasia, involving abnormally developed tissue, cystic dysplasia, and terminal differentiation defects. In addition to these kidney defects, there are a wide array of anatomical variations such as ureteral duplications, renal duplex system, ureteral ectopia, and ureteroceles. These anomalies arise from the complex development of the urinary tract and have significant clinical complications. One particular condition I would like to highlight is the duplex kidney, considered a congenital anomaly of the kidney and urinary tract. It's also known as the duplicated collecting system, And this occurs when the ureter and or renal pelvis, the structures that drain urine from the kidney to the bladder, are duplicated. This duplication happens during fetal development, due to errors of embryological formation of the urinary system. Duplication of the renal system is one of the most common congenital anomalies of the urinary tract. Interestingly, the majority of these anomalies remain clinically silent and are often discovered incidentally during imaging studies for unrelated issues. When treatment may not be necessary in asymptomatic cases, or if the duplex kidney is functioning well without causing urinary tract infections, obstruction, or reflux, active treatment isn't usually required, although those patients need regular monitoring through periodic checkups and imaging that can ensure that no problems develop over time. Duplex kidneys are actually more common than you might expect. They occur in about 1 in every 125 live births, which means they are present in approximately 1% of the general population. Some studies even report a prevalence ranging from 0.8 to 2%. Interestingly, duplex kidneys are more commonly found in females than in males. The condition can affect one kidney or both kidneys, but unilateral cases are more common. They are seen bilaterally in 15 to 14% of cases. What's notable is that many cases remain undiagnosed, as I told you earlier, because they are often asymptomatic. In fact, duplex kidneys are frequently discovered incidentally during imaging studies conducted for unrelated medical issues. Children with duplex kidney anomalies are at a markedly. From the developmental point of view, the duplication of the urinary collecting system can occur through several mechanisms: by multiple ureteric buds formation, by early bifurcation of the single ureteric bud, by abnormal ureteral bud insertion, and the overexpression of GDNF red signaling pathway is a significant factor here. GDNF, produced by the metanephric plastema, binds to the RIT receptor on the ureteric bud cells. When this pathway is overexpressed, it can induce the formation of multiple ureteric buds from the mesonephric duct. Each bud has the potential to develop into a separate ureter, leading to complete or incomplete duplication of the collecting system. Here on the left side, you can see an illustration of the process of double ureteric buds formation. During early development, the kidneys lie close together in the sacral region of the embryo. However, as the abdomen enlarges, the kidneys are drawn apart and ascend to their final position in the lumbar region between weeks 6 to 9. The kidneys begin their migration from the pelvic area to the final position in the lumbar region of the abdomen. This process is known as the ascent of the kidneys, though it's not due to an active migration probably, but rather due to the differential growth of the embryo, particularly in the caudal part, which elongates faster than the cranial parts. As the kidneys ascend, they undergo a 90-degree medial rotation. Initially, the hilum of the kidney faces anteriorly. As the kidney ascends, the hilum rotates medially so that by the time the kidneys reach their final position, the hilum faces medially towards the vertebral column. On the right, you can see the typical scenarios. First, a mega-ureter of the upper moiety. Second, a refluxing ureter to the lower moiety. And third option, both a mega-ureter and a refluxing ureter. The renal embryology leads us to an important concept, that is the Weigert-Mayer rule, which helps us understand the ureteral insertion in duplex systems. The ureter from the upper pole often inserts ectopically, inferior and medial to the normal ureteral orifice. This ectopic insertion can lead to obstruction or formation of a ureterocele. The lower pole ureter inserts at the normal location but is more prone to vesico-ureteral reflux due to a shorter intramural course. Rarely reported in the literature, the ectopic pathway, sometimes called the pathway of Stevens, postulates that an ectopic ureter may drain not only distally to the normal ureteric orifice, but may drain medially and superiorly to it, violating the Weigert-Mayer law. And it is said that the Weigert-Mayer rule is accurate in 85% of cases. There are several ways we can classify the duplex kidney. In incomplete duplication, the two poles of a duplex kidney share the same ureteral orifice of the bladder. Single ureteric path bifurcated before it reaches the ampulla, premature branching event that occurred before the ureter has reached the mesenhyme. Complete ureteral duplications are much more frequent. Very rarely, an H-shaped ureter has also been reported, although the vast majority of cases involve a simple duplication. Multiplex ureters with up to 6 independent buds have also been described, and also cases like congenital ureteral diverticulum have also been described. So on the previous slide, we had the classification based on completeness of duplication, but we can base it also on ureteral insertion. So we may have an orthotopic ureter when ureters insert at the normal anatomical position in the bladder trigon, and an ectopic ureter when the ureter inserts outside the bladder trigon, for example in the urethra, in the vagina in females, or other genital structures. And in females, this may lead often to urinary incontinence. We can also base the classification on an association with a ureterocele. So we can have a ureterocele, one of the duplicated ureters ends in a ureterocele, which is a saccular dilation of at the bladder end, or without a ureterocele, when there is no ureterocele formation. We can base the classification on renal function, and we can have a functioning duplex system where both upper and lower pole renal moieties are functional, or dysplastic non-functioning upper or lower pole. Commonly in complete duplications, the upper pole may be dysplastic or non-functioning, often requiring excision, but it may happen that the lower pole is the non-functioning one. We can classify the cases based on symmetry, so we can have unilateral duplex kidney when the duplex system is on one side with the contralateral kidney being normal. We can have bilateral duplex kidney where both kidneys exhibit duplex systems which may be complete or incomplete on either side. And we can classify the cases based on gender presentation. They are more common in females, but they may also happen in males, which is less common. We can see an association with a posterior ureteral or seminal vesicle anomalies in males, and we never have cases of incontinence in males. On this 3D CT reconstruction, we can see a complete duplication of the kidney that is unilateral with probably orthotopic ureters, the lower pole probably with vesico-ureteral reflux, as we can see that renal calyces and renal pelvis are enlarged. As we move on to another sections of this presentation, I wanted to tell you a joke, and I had a very secret urology joke for you, but it leaked unfortunately, and now it's flowing freely. Okay, never mind, let's dive back into our discussion on duplex kidney anomalies. Duplex kidney anomalies can be associated with chromosomal abnormalities like trisomies 13, 18, and 21. Additionally, associations like the Vactor's association include renal anomalies such as duplex kidneys. Duplex kidneys have been also described in bronchio-otorenal syndrome or in Fraser syndrome, in Townes-Brooks syndrome, Kallmann syndrome, or Pallister-Hall syndrome. An interesting case where we can see in a syndrome a duplex kidney is the obstructed hemivagina and ipsilateral renal anagenesis syndrome. Both the syndrome and ureteral duplication arise from abnormal development of the Wolffian and Mullerian ducts, and this syndrome is characterized by Mullerian duct anomalies, typically uterine didelphys and obstructed hemivagina and ipsilateral renal agenesis or dysplasia. The ureteral duplication can be associated with the renal anomaly here, and the ectopic ureter may be found in the position of an abnormal termination in the vagina that contributes to the obstruction. So the ureteral duplication here can exacerbate the obstruction caused by the obstructed hemivagina, leading to further complications infection, pain, and hydronephrosis. Surgical correction is needed in such a condition. When it comes to the clinical presentations, as I told you earlier, many cases can be asymptomatic, especially in adults. However, in children, we often see symptoms like recurrent urinary tract infections, urinary incontinence, or signs of obstruction such as hydronephrosis. There is a notable gender difference. Girls are more prone to incontinence because the ectopic ureter may insert below the external ureteral sphincter, leading to continuous dribbling. Boys, on the other hand, usually don't experience incontinence because the ectopic ureter inserts above the sphincter. There are several signs in clinical presentation that may suggest the presence of a duplex anomaly. For example, a failure to thrive and poor gain weight in infants and young children may be associated with chronic kidney issues or recurrent urinary tract infections that may be associated with the duplex kidney anomalies. Hypertension, less commonly, but also the elevated blood pressure may occur due to impaired kidney function of one of the poles of the duplex kidney. In cases of an enlarged kidney resulting from hydronephrosis, a palpable mass may be felt in the abdomen. It may be caused by the ureteral obstruction, can be felt in the abdomen, mid-abdomen, or in the flanks. There may be a costovertebral angle tenderness present upon percussion. During the genitourinary examination, a continuous urinary dribbling may be seen in girls. Sometimes the parents may think that this is a normal condition and that it isn't anything special in the patient. It's important to know that in such a case, normal voiding patterns may be also present. A perineal irritation or rash caused by the constant moisture may be also present, signs of urinary tract infections, and also signs of associated anomalies like limb abnormalities, spinal deformities, anal abnormalities. So a thorough examination is very important to find the possibility of existence of a duplex kidney. One important condition associated with duplex kidneys is the ureterocele. a cystic dilation of the terminal ureter, either within the bladder or extending into the urethra. We classify the ureteroceles as intravesical ureteroceles when they are located entirely within the bladder, and ectopic ureteroceles that extend beyond the bladder neck into the urethra. More frequently, the ureteroceles are found in females, and in 80% of cases they are associated with the duplex collecting systems, more commonly with the upper pole. Ureteroceles in duplex systems are also often ectopic, and bilaterally they occur approximately in 15% of cases, while 85% are unilateral. Probably the ureterocele is caused by a stenotic ureteral orifice or abnormal ureteral insertion at the bladder, and embryologic factors that cause the ureterocele may include incomplete breakdown of the ureteral membrane called the Chvalas fascia, or obstruction caused by delayed ureteral bud insertion. Small ureteroceles may be often asymptomatic, but may cause urinary incontinence in females, urinary tract infections, or rarely, when they are very large, urinary obstruction. Fortunately, ureteroceles are increasingly detected via antenatal ultrasonography. And in US, UK, and Europe, most ectopic ureters are associated with the duplex kidney. But in other regions, like in India or Japan, single kidney systems with ectopic ureters are more common. Here on the video, you can see how we deal endoscopically with a large ureterocele as a first-line treatment. A small number of patients with duplication of the renal system become evident as a consequence of hydronephrosis, vesicoureteral reflux, or incontinence. The diagnosis often begins with the prenatal ultrasound, where hydronephrosis or uteroceles may be detected. Postnatally, ultrasonography is the initial imaging modality. Voiding cystourethrography may be essential for detecting vesicoureteral reflux. Magnetic resonance urography with the functional analysis provides detailed anatomical information without radiation exposure. That makes it ideal for pediatric patients. Although CT scans offer excellent details, their use is limited due to radiation concerns. Nuclear medicine studies like DMSA scans help assess cortical function, and MAC-free renography evaluates drainage and function, guiding the treatment decisions. Functional magnetic resonance urography is a technique that is used in our hospital, and several papers have been published up to date regarding this technique. This is an advanced imaging technique designed to assess both the anatomical and functional status of the kidneys and urinary tract. It merges conventional magnetic resonance imaging with additional functional capabilities, enabling it to measure renal excretory function while producing high-resolution images. Functional MRI urography combines dynamic imaging sequences to visualize the urinary tract and quantify renal function. It leverages two principal MRI techniques, the T2 weighted imaging and T1 weighted imaging. The T2 weighted imaging is a non-contrast technique, also called hydrography, that provides high-resolution images of the urinary tract, specifically visualizing fluid-filled structures like the renal pelvis, ureters, and bladder. T1 weighted imaging, post-contrast administration. This dynamic imaging technique uses gadolinium-based contrast agents to evaluate renal perfusion, filtration, and drainage. These combined methods enable both static and functional imaging of the kidneys collecting systems, ureters, making it superior to traditional imaging modalities like ultrasound or nuclear scintigraphy, especially when radiation-free diagnostics are preferred. The data acquired during functional magnetic resonance urography can be processed using software tools such as CHOP-fMRU or PMRE, which stands for Parametric Magnetic Resonance Imaging. PMRI is a CHOP-fMRU successor that allows detailed analysis of several parameters, including differential renal function. It's measured based on the volume-enhanced parenchyma and PATLAC differential renal function. These tools help to assess kidney functionality in cases of complex urological anomalies, such as the duplex kidneys or obstructive uropathies. We can measure renal transit time. This is the time that it takes for the contrast to transit from the kidney to the ureter, which can be categorized into normal, moderate, or severe obstruction. fMRU often complements or replaces traditional imaging techniques. Even though ultrasound is often the first-line imaging modalities, it may miss more complex or subtle functional anomalies that fMRU can detect. Nuclear scintigraphy with MAC3 or DMSA scans can measure renal function and obstruction, but is limited by lower spatial resolution and radiation exposure. fMRU can replace scintigraphy for functional assessment in many cases, especially in pediatric patients. We can calculate split function and volumes, generate enhancement, histograms, functional maps, and a lot of more. We can analyze also multiphase renal scintigraphy studies for split function and perform many more tasks using this software. Here you can see images from one of the older publications of the Department of Radiology from our hospital. The T2 weighted image on the left in coronal plane is of a right kidney with a megaureter. In the picture B on the left side you can see the maximum intensity projection reconstruction image of the right kidney collecting system with the megaureter. In picture C, the same patient with reconstruction in 3D volume rendering technique. On the right side, you can see a case of a 3-month-old female with left-sided megaureter. The T2 weighted image in the coronal plane shows left kidney with the megaureter. On picture B, you can see an intraoperative picture of the partially excised megaureter. And in picture C, the T2 weighted image in coronal plane presents advanced dysplasia of the right kidney and localized dysplasia in the left kidney. Here you can see the analysis of renal functional MR urography on the left side and scintigraphy on the right side of a duplex right kidney with opal pore megaureter. There is a graphic representation of kidney segmentations, absolute values of fMRU and scintigraphy parameters, and at the bottom enhancement curves. In fMRU, the enhancement curves and differential renal function are taken separate for each moiety of right kidney. The main image on the right, presenting scintigraphy analysis, elongated time of T-half maximum of the right kidney due to radiotracer retention in upper pole. When it comes to treatment, there are several aspects that need to be taken into consideration. The first one is the upper tract versus lower tract approach. In the upper tract approach, if the upper moiety of the duplex kidney is a non-functional or obstructed, an opal pore heminephrectomy may be required. This is common in cases where the ureterocele affects the upper pole and causes obstruction, leading to hydronephrosis or poor kidney function. If salvageable, reconstructive surgery such as ureterostomy can be performed to preserve the function. The lower tract approach. Ureteroceles located at the bladder neck or urethra can be treated by endoscopic puncture, which is a minimally invasive procedure. In cases where the compression is inadequate or the uterocele is associated with significant vesicoureteral reflux, a ureteral reimplantation may be necessary to prevent reflux and restore normal urine flow. We have to differentiate between minor and major procedures. Maybe not always the major procedure is the best way to treat the patient. In case of the minor procedures that include endoscopic puncture or incision of the uterocele, can be done safely as a single-day surgery. This approach is often chosen for smaller intravesical ureteroceles that are causing mild obstruction. However, this may require follow-up surgeries if the decompression is incomplete or if other anomalies develop. Major procedures are more extensive surgeries such as heminephrectomy or complete ureteral reconstructions. They may be necessary for severe cases where significant portions of the kidney are non-functional or where there is significant anatomical disruption, such as in ectopic ureters. Then we need to differentiate between ablative and reconstructive procedures. Ablative procedures include partial or total nephrectomy. Upper portal nephrectomy is more common in cases where the upper moiety is non-functional due to obstruction caused by a uterocele. It is rarely the first choice unless the kidney function is severely impaired. The reconstruction options are also plausible if kidney function is preserved. Procedures like ureterostomy or ureteral reimplantation are preferred to avoid long-term complications, such as a reflux or obstruction. Reimplantation repositions the ureter in the bladder, especially in cases where reflux or obstruction persists after the decompression. So the overall treatment decisions depend on the extent of the obstruction, the function of the renal moieties, and the presence of associated conditions such as vesicoureteral reflux or ectopic ureters. Most patients, especially with early interventions, can expect fortunately good outcomes with minimal long-term complications. A standard treatment option for a duplex kidney, usually when it comes to the ablative procedures, is the upper pole laparoscopic heminephrectomy. In 1993, Jordan and Winslow successfully carried out the first laparoscopic transperitoneal heminephrectomy in a 14-year-old child. It's worth mentioning that this patient had a bilateral duplication and was operated on the other side after a few months. There are several approaches, in fact, how we can perform the heminephroureterectomy. We can use the open approach, surgery through either a flank or dorsal lumbotomy approach. We can use the laparoscopic approach with robotic assisted surgery. Nevertheless, the most important factor is to avoid damage to the viable lower pole and lower pole ureter, or in cases when the upper pole is viable, to avoid the upper pole injury. Dissection is performed immediately on the wall of the upper pole ureter in order to preserve the blood supply to the healthy lower pole ureter. But as I told you that laparoscopy is the approach of choice in case of duplex systems, there are several also approaches that can be used within the laparoscopic approach, like the posterior retroperitoneal or lateral retroperitoneal, laparoscopic transperitoneal, or robotic approach. In our department, we use in most of the cases the laparoscopic transperitoneal approach. Now I would like to show you the case of a simultaneous laparoscopic heminephrectomy in children with bilateral duplicated systems. We find it feasible to perform, and we believe that this is the procedure of choice. Recently, we operated on 7 children using a 5-port approach. Both sides were operated on during single surgery. The mean age of those patients were 8.7 months, and the weight of the children was around 10.8 kilos. On the slide, you can see the trocar port setting for this approach. Red and blue ports were used while operating both sides. 5 ports were placed, but only 4 were used during surgery on one side. The patients were positioned supine. The table position was adjusted according to the operated site. The colonic flexures were mobilized on both sides, and the dilated ureters were identified and dissected up to the upper pulse and resected with selective clamping of arterial branches. It took 137 minutes on average to perform this surgery. The blood loss in all cases was minimal, mean post-operative stay was 2.4 days, and the cosmetic results, as you can see on the photo, were excellent. So, in children with bilateral duplicated urinary tract with ureterocele, ectopic ureter, and or versico-ureteral reflux, laparoscopic transperitoneal repair can be accomplished safely in a single operative procedure during the same anesthetic administration with a short hospital stay. Now I'm going to present the procedure of laparoscopic transperitoneal heminephrectomy of the lower pole of the right kidney. The surgery was conducted under general anesthesia. The patient was positioned on his back and the right side was slightly elevated. After placing both the bladder catheter and the nasogastric tube and preparing the surgical field, we made a small incision at the umbilicus to introduce a 12 mm trocar, especially for a 3D camera. Carbon dioxide insufflation was used with a pressure of 10 mm of mercury in order to create a working space in the abdominal cavity. 2 additional 5 mm trocars were inserted along the midline above the umbilicus, and another 5 mm trocar was placed in the right lower abdomen. Once the hepatic flexure of the colon and the ascending colon were gently moved medially, we could clearly visualize the lower pole of the kidney, along with both ureters. We then proceeded to dissect and isolate the enlarged ureter, which drained the lower pole, and cut it using a ligature knife. Next, we exposed the renal hilum and identified the kidney's blood vessels. The vessels supplying the lower pole were carefully coagulated with ligature, effectively cutting off blood supply to this region. We then resected the ischemic part of the lower pole at its boundary. Hemostasis was well controlled. Following the excision, we moved on to the bladder area, where we isolated the enlarged ureter near its attachment to the bladder. After applying the hemlock clip, we transected the ureter. The upper segment of the kidney and the remaining ureter were confirmed to be well perfused. Finally, the resected part of the kidney, along with the ureter, was removed using a retrieval bag through the camera port at the umbilicus. We closed the abdominal layers with sutures and applied sterile dressing. You may feel surprised by the video, and it's because it was not a typical situation for duplex kidney. In the case presented, there was a severe hydronephrosis of the lower pole. On the MRI scan, we could see a significantly faint parenchyma, only up to 3 millimeters. The upper pole appears normal and constituted 1/3 of the kidney. The parenchymal thickness was of 11 to 12 millimeters. The lower ureter was narrow, and the left kidney showed compensatory hypertrophy in this case, with normal signalar and normal corticomedullary differentiation. When we performed the functional MRU urography, we could see that there were signs of significant damage to the lower pole of the right kidney, with severely reduced function, less than 10%, and mild urinary outflow obstruction due to uretero-pelvic junction stenosis. Another procedure that is being performed is the ureterostomy. This is an example of an upper tract approach, and it's often a successful and a safe option, even in cases with minimal function in the upper pole, and even in cases with a large size disparity between the upper and lower pole ureters. It is possible to do via an inguinal incision that's extended in order to minimize visible scars, and end-to-side anastomosis is favored in these cases. More recent studies have shown that children may be adequately treated with just one or at most two less invasive procedures, which may include endoscopic puncture combined with upper pole heminephrectomy, obviating the need for two separate incisions. Whereas the total reconstruction is an example of a radical surgery, where the upper pole nephrectomy is being performed, the ureteroceles is being excised, and the lower pole ureter is being reimplanted to the bladder. Now I would like to present 3 selected studies of the surgical management of duplex kidneys. The first study by Paraboshi et al., Surgical Management of Complicated Duplex Kidney at Tertiary Referral Center, 10-year experience, presents the outcomes of surgical interventions for complicated duplex kidneys over a decade at a single pediatric referral hospital. The key findings include the sample. The study analyzed 95 children who underwent surgical treatment for 102 duplex kidneys between 2009 and 2019. The most common anomalies were ureteroceles, ectopic ureterals, and vesicoureteral reflux. Surgical interventions included heminephrectomy, that was the most common procedure, and 70% of patients undergoing this invasive surgery. The endoscopic approaches were less common. Children diagnosed postnatally or with upper tract obstructions had a higher risk of developing urinary tract infections that were recurrent. Antenatal diagnoses were linked with fewer complications. Despite the variety of surgical approaches, no standardized management plan could be recommended. Children without antenatal diagnosis or with upper tract issues or vesicoureteral reflux required close monitoring. In conclusion, the study suggested that surgical management of complicated duplex kidneys remains complex, with no one-size-fits-all solution. Minimally invasive surgery has become more popular, but more invasive procedures like heminephrectomy remain common in treating severely affected kidneys. Considering only the definite procedure performed, 30 renal units were treated endoscopically, while 91 underwent a major surgery. In this subgroup, 77 cases were ablative surgeries. The second study by Chen et al., titled Laparoscopic Ureteral Anastomosis for the Treatment of Complete Duplex Kidneys in Children, discusses the use of laparoscopic surgery for treating ureteral deformities associated with complete duplex kidneys. The study analyzed the cases of 35 children aged 5 to 51 months, treated from June 2018 to July 2020. The procedure involves laparoscopic ureteral anastomosis, which has the advantage of preserving renal function, causing less trauma, and facilitating quick recovery. The study showed significant improvements in ureteral hydronephrosis and renal parenchymal thickness after surgery. The authors conclude that laparoscopic ureteral anastomosis is a safe and efficient treatment for children with duplex kidney, showing favorable outcomes with less trauma and rapid recovery. The final study, titled Results of Ureteral Anastomosis in Pathological Duplex Kidney, evaluates the outcome of ureteral anastomosis in children with duplex kidneys over a 20-year period. This is one of the first studies to compare three distinct ureteral anastomosis techniques via laparotomy, laparoscopy, and combined approaches. It provides us with comparative data on operative times, hospital stays, and complications rates. The study's findings on the successful rates of these techniques can guide us in choosing the most appropriate surgical approach for our patients. The study supports a conservative surgical trend by favoring ureteral anastomosis over more invasive procedures like nephrectomy, which could potentially impact long-term renal function. It challenges the traditional view of automatically removing non-functional renal poles, advocating instead for techniques that preserve function and reduce the need for complete nephrectomy. So, the take-home messages of this webinar is that early detection is vital for optimal outcomes. Early detection of these anomalies is essential to prevent serious complications like renal damage and recurrent urinary tract infections. Timely intervention can significantly improve patient outcomes. Genetic and embryological insights drive understanding. A deep understanding of these mechanisms is crucial for accurate diagnosis and targeted treatment, and there is a vast field for improvement. Clinical presentation is diverse and gender-specific. These anomalies can present in various ways, from being completely asymptomatic to causing significant issues like urinary incontinence in girls due to ectopic ureters. Recognizing these patterns is key to effective management. Comprehensive diagnostic evaluation is essential. Utilizing a combination of imaging modalities like ultrasonography, voiding cystourethrography, magnetic resonance urography, and nuclear medicine studies ensure a thorough evaluation of urinary system, helping to identify all associated anomalies and guide treatment. Although we support the use of functional magnetic resonance urography over other techniques. Finally, contemporary minimally invasive treatments offer excellent outcomes. Those techniques, including laparoscopic procedures and endoscopic interventions, provide effective and less invasive options for managing duplex kidney anomalies. These approaches help preserve renal function and improve patient quality of life. Thank you for your attention.
Hi everyone. Apologies once again that we don't have our presenter here tonight to answer the questions, but it really was an unavoidable situation. But we thought it best to go ahead with the webinar anyway. So if you have any questions, you can type them in now to the Q&A. So I'll give, while people are just doing that, if you want to, I will just give a few other messages. It's when the webinar ends, you will see a survey pop up straight away. You can choose to answer it immediately, but you also get an email in about an hour's time with a link to the survey as well, so you can answer it later if you wish. A reminder that if you do want to claim CME points for this accredited webinar, you will need to fill the survey in. You can also, if you think of questions later, you could also either email me. You should have my email address, it's darren.shulhan@radboudumc.nl, or you can also put them into the survey as well if you fill that in later. Question 10 is a free format field, a free text field that you can use to ask the questions there. We'll take the questions away and we will get Dr. Anzelewicz to answer them. We'll either then post it as an extra video or put them onto the website. We'll send a link to everybody about that. And tomorrow we'll also send a link to the recording as well to all registrants for this. The recording will also go to YouTube, so you can watch that. And also I would kind of recommend you go on there if you haven't already, if not familiar with it. You can subscribe to that to get notifications when extra videos, newer videos are put on. And you can also look back through, over 100 webinars on there now that you can look back through as well. The links will also go on the website, and on there's a record of all the webinars we've done by expertise area, which we divide our organization into. So if you look on the website as well, you can find things on particular topics as well. So I think that's everything I was going to say. I see questions are coming in, so thank you. So while that's happening, I'll just won't end the webinar quite yet. So we'll let people know once we've done the answers, and I will email out to everybody to let you know. I'm just going to make sure because we started using Zoom recently, I'm going to take a screenshot of these because I couldn't find them in the system earlier where I get the questions. So we are still learning a little bit, some of the background things. So I'm just going to do that now. 1 second, hope this won't affect your abilities at all. I'm just going to screenshot this. Apologies for the effects sound. Great, I think there's one more there. Okay. Try to copy. It's not letting me do that, so I'm going to take another screenshot. Okay, I think things will stop coming in. So as I say, if you think of anything afterwards, please feel free to send it via email or through the survey as well. That's absolutely fine. But for now, thank you all very much for attending. I hope that was interesting. If you yeah, any other comments about anything with the webinars, please put them into the survey as well. That would be much appreciated, as Michelle mentioned at the beginning. So thank you, everybody. I hope so that was useful, and we'll see you all again at our next webinar. We have quite a full program going forward for the next few weeks, so that can be found on our website as well. And the registration links will be put up there as soon as we have them as well. Thank you very much, everybody. Take care and have a good evening.